Good morning, everybody. My name is Kathy Lyons. I'm one of the nurses on the Center for Reproductive Medicine. Today we are here on April 6th to do the Ovulation Induction / IVF class. We're going to talk about the protocols for each of these specific programs, especially focusing on the meds, testing, etc. I've kind of made a little outline on the board here, so it gives you a timetable. This first piece should last about an hour and 10 minutes. We're then going to break. So those of you that are moving on to IVF will remain. I'm going to take those of you in ovulation induction upstairs to meet with your nurse for the one-on-one to review your individual protocols. In each of your folders, you will have a packet, a handbook kind of outlining everything that we're going to be going over to today, so you don't have to feel like you have to furiously write everything down. There's a booklet in each of your packets that is basically going to outline each of the protocols, the meds, just kind of a nice referral. So if you have any questions, most of them are answered in this booklet. As always, your nurse is available to you Monday through Friday. The office is open 8 to 5. There is a voicemail system that is available to you between 8 and 4:15. However, a lot of patients feel once 4:15 rolls around, they have no way to get in touch with their nurse, and that's not true. The lines are open until 5 o'clock, so even though the voicemail might shut down at 4:15, you have access to the secretary at the main number, 617-732-4222. And that number, again, is good from 8 to 5. However, you have access to talk to somebody 24/7. After the office closes at 5, one of our fellows, they are the Fertility and Endocrinology Fellow, you might hear them referred to as the F&E Fellow. They are available to you after hours should you have any questions or concerns. So you're never left out there by yourselves with no recourse and nobody to talk to. Again, all those numbers for after hours, everything is in the booklet. So should you have a pressing question, a problem, a concern, you do not have to wait till the following morning at 8 a.m. However, our fellows are not here in the building. They are in their own home. So they have said to us on occasion, Mary Brown called me at 3 a.m. with a question that could have waited. Obviously, I'm going to ask you to be mindful that they are home in their own beds. They're not living here. So if there's a problem that can't wait, we want you to call. But otherwise, we'd ask that you try to do all the questions or any concerns that you might have with your nurse during office hours. We are an ambulatory clinic, so we work collaboratively with many of the physicians, PCAs, the fellows, the nurses. So even though you have been seeing a primary physician, also known as an attending physician, they are not here 5 days a week. They not only do office hours, they have OR schedules as well as IVF duties, and a lot of them work at some of our satellite facilities. So don't be alarmed if you have Dr. Ginsburg and you've been doing a lot of work with one of the other physicians, etc. We all work collaboratively. So I just want you to be aware of that there's a big collaborative group going on to meet your needs. Whether you're doing IVF or ovulation induction, obviously it is going to be, these cycles are going to be driven by medications. And the medications are injectable. Wish we had a lot of oral medications, but we don't. And obviously it takes a lot to come here today. We know it's a big step. We know it's pretty intimidating and sometimes even terrifying for some of the patients. Please know that we're here to walk you through it. No one expects you to leave class today and be able to go home and be an expert at it. We know most people go home and say, I don't remember one thing that woman said, and that's fine. We're here to walk you through it. You're never going to be by yourselves. That's why we like doing these classes, meeting with you one-on-one, being able to identify what your concerns are and helping you through it. So as tough and as hard and as difficult as this can be, we're here to help you. We have excellent resources should you need to talk to somebody. I mean, sometimes you just need a vent and say, this is horrible. We know it is. We know that no one's here because they've got nothing else better to do. So we want you to know that we're aware of that. And please call us if you're having any difficulties. That's what we're here for. When we start these cycles, as I said, it's going to be using a lot of different medications, and sometimes in combinations. A lot of times with the ovulation induction cycles, it's just 1 or 2 meds and that's it. Sometimes with the IVF cycles, there are overlaps with meds, there's different combinations, and that's why we want to meet with you afterwards one-on-one to review the different protocols. So while I review all the meds, don't think, oh my God, I'm going to be on all that. You're not. Okay? But what you're using, you are not. So we need to make everybody familiar. And again, I don't mean to keep beating a dead horse, but we are going to meet with you one-on-one to review your individual protocols so that you fully understand and are comfortable with what you're going to be doing. All of the medications that are used, most of them are injectable. So most people, as I said, find this a little intimidating. I'd be concerned if I ever came across a patient that said, oh good, we get to use the needles now. Most people are obviously the opposite. All of the medications are used to drive the ovary to make more than the one dominant follicle it does all by itself. Obviously, the more follicles, and which, by the way, are fluid-filled sacs with an egg inside. Those follicles, we're hoping to get more than one, thereby increasing your chances of getting pregnant. When you start your cycle, you're either going to start when you're doing ovulation induction. All of them start with day 1 of your period. So if you're doing ovulation induction, you get your period, you call your nurse. You would then be instructed to do an ultrasound on day 2 or day 3. That baseline ultrasound is done on every patient before they start meds, just to make sure there's nothing going on with the ovary. We certainly are not going to stimulate a patient who's got anything on their ovary, such as a cyst, a polyp, a tumor, any type of growth. We do not want to compromise, an ovary that's already got stuff going on. So with that baseline ultrasound, once it's done, it's reviewed by your physician. The nurse will then call you with instructions to start your medication, which, by the way, if you're doing ovulation induction, would be day 2 or day 3. Day 1 for everybody of your cycle is the day that you have full flow. So if you tend to spot or stain, that's not day 1. That's spotting or staining. Full flow is an actual flow. And if you get it at 10 minutes to 12 or before your head hits the pillow, that's day 1. Don't think, well, I got my period at 11:45, in the evening, so that's not day 1. It is. Okay? You would then baseline on day 2 or day 3 if you're doing ovulation induction. If you're an IVF patient, when you get your period, you're going to call your nurse, because you're either going to go on birth control pills or be asked to abstain from any unprotected intercourse. With IVF, we do not start your cycle right with your period. We need to be absolutely sure that there's no chance that you could be pregnant before we start these meds. And since we don't start you like we do the ovulation induction patients on day 2 or day 3 of your cycle, you have to either abstain or use birth control pills. So once we can determine through those resources that there's no chance that you're pregnant, we can then verify either with a blood test, which is a progesterone blood test. We'll verify that you've ovulated, and then we would start your meds. Okay, so it's a little bit different, and again, just don't want you to be confused with the way we start the different cycles. If you're on birth control pills, obviously they're going to, we use them to downregulate, also what we call inhibiting your LH and FSH production. So it's going to downregulate your hormones. We also use it sometimes to regulate cycles. So people that don't ovulate or have, crazy periods where they're not always, getting their periods on a monthly basis, we can use the birth control pills to regulate things. Lupron. This is used mostly in IVF cycles, but it does come in a kit. It's also called leuprolide acetate. So a lot of times you're going to hear a med and you might get it sent to you in a generic form, but we'll review that with you to make sure you're comfortable and know what you're taking. Lupron is an inhibitor. It tends to suppress estradiol and progesterone production. So we use this, especially with the IVF cycles, as a suppressant. When we're manipulating your cycles, your brain is sending signals all the time driving the menstrual cycle. We don't want spikes of estradiol and progesterone if we're manipulating, so we use the Lupron to suppress. You're using very small amounts, and you'll be instructed when to take it. Typically with the IVF cycle, as I said, you're on pills or you're on the asked to abstain from unprotected intercourse. We have you come in on the 21st day of your cycle to do a progesterone blood test. Once that's verified that you ovulated, you're then asked to take Lupron. Lupron comes in a kit such as this. Everything you need is going to be in it. It has its own syringes, which actually look like insulin syringes. And typically the amounts can be anywhere from 10 to 5 to 4 to 2. You'll be asked, and you'll know what you're taking because it's going to be outlined in your protocol. The syringe is one piece. It has a very small needle. This is used for subcutaneous injections. Subcutaneous injections are just those injections that are just below the surface of your skin. So when we instruct you, when we meet with you upstairs, we're either going to be instructing you to do it in your abdomen, the top of your thigh, or the back of your arm. But it's very difficult, to do the back of your arm. You might need a partner to do that for you. So everything is in the kit. It does have a multi-dose vial such as this. So you'd be wiping the top of the vial. It's a rubber-based stopper every time you use it with alcohol pads. And when we talk about the meds and we order them for you, all of these will be included in the package of the kit that you'll get from the pharmacy. So when you take the Lupron, you wipe it with alcohol. Depending on your dose, we recommend that you pull the plunger down. So if you're on 10 units, you'd pull the plunger to the 10-unit marker. You've wiped the top of the Lupron bottle with alcohol. Plunge that air in, tip it upside down, and draw out what you need. Okay? Once you've finished the injection, you're then going to be provided a Sharps container. You're just going to dispose of the used syringe that way. So this is Lupron. Again, it's used primarily in the IVF cycles to suppress the hormones that spike during a cycle, allowing us the ability to manipulate it. The other medications that we use, obviously, are the FSH meds, which are the medications that are primarily going to make the eggs. Follistim comes in a pen, which is just like this. All of the meds that you need are in this cartridge. So when you get the pen, you're just basically going to put it in the yellow piece. This piece twists in. It's very easy. There's no mixing involved. Whatever your dose is, you're going to dial it up. It'll be visible in the window. All of your meds, as I said, when you get them, are going to have everything you need. This is the particular needle for the Follistim. You're going to wipe this. Always wipe with alcohol. The needles are only going to be used once and then discarded. In the event while you're getting the injection ready, you somehow bump it against the table, against yourself, the needle is contaminated and you need to put a new one on. Once again, you've dialed up your dose, depending what it is. Take this cap off, the second cap, and now you're ready to do your injection. Again, these are what we call subcutaneous injections. The needle is very small. It's usually only a ½ inch long. It's not going anywhere but below the surface of your skin. Because I've had people say, oh, I don't want to give it in my abdomen. What if I hit my kidney? You're not. It's not that big of a needle. It's very small. Again, you're always going to prepare this injection site with alcohol swabs. You're going to either wipe it. We ask you to pinch an inch, 1, 2, 3, like a dot or a pencil, 1, 2, 3 in, and then you're just going to press on the plunger. You'll know you're done because the window will now say 0. Okay? And again, we're going to go over this more in depth when you're upstairs with your nurse. Once you're done, you're going to just twist off the needle and you'll put it in your Sharps container. The thing with Follistim is once it's open, that particular medication cartridge needs to be protected from light. So you want to cover it up and put it in your refrigerator. that med does need to be refrigerated after you've used it. So if you've peeked on your sheet and said, oh, I'm on Follistim, and again, we'll go over that with you. The other FSH that we use is Gonal-F. And let me say how the meds are decided. Both of them are equally the same. They're going to do the same job. They're going to drive the ovary. How it's decided who gets Follistim and who gets Gonal-F is really your insurance companies. As you know, Massachusetts is one of the few states in the country that has insurance for this type of protocols. And because these meds are quite expensive, most of your insurance companies have engaged in contractual agreements with the different pharmaceutical companies as well as the different drug manufacturers. So pretty much that's been dictating what med you'll take and where you'll get them from. And again, depending on your insurance, again, we'll go over that with you when we meet upstairs. Gonal-F is not pre-mixed. Unlike the Follistim and the Lupron, where you're just drawing it up, the Gonal-F comes in a powdered form that you would need to add diluent to. So in each box, there is a vial of Gonal-F. Depending on your doctor who has determined what dose you'll take, you could be taking 1 or 8 of these. So if you're told to take 2 powders, you'd open up 2 of these boxes. You'd line the powders up, 1, 2. Again, you're going to wipe each one with alcohol. You're then going to take the vial of diluent. And one thing with Gonal-F now, I'm sorry, it does come pre-filled. They've changed it. They've made it a little bit easier. This is a pre-filled syringe with the diluent that you're basically going to put into the vial of powder. Okay? And then you'll draw up the entire amount. Usually they give you a big needle and a small needle in this package. The big needle, obviously, you need that length to be able to draw up the medication. Once you've drawn it up, you then need to switch from the big needle to the small needle, and then you'd inject the same way you would the Follistim or the Lupron. Okay? So Gonal-F, a little bit more work involved. It's not readily mixed. You're going to have to do the mixing. So whether it's 1 vial or 8, you're going to take just 1 pre-filled syringe, put it into the first vial, draw it all up. If your dose is 2 vials, you're going to take now what's in here, in this syringe, put it into the second vial and draw it all up. So whether you use, your dose is 1 or 8, you're only going to use 1 syringe or 1 cc, which is already in the syringe for you, ready to roll. Okay, so it's not 8 cc's. That would mean you'd have to give 8 separate shots. It's going to be 1 cc despite whether you're using 1, 2, 3, or 8 vials of medication. Those are the primary meds that we use to stimulate the ovary, Follistim and Gonal-F. However, sometimes they feel if you've had poor response in the past, say you've done cycles at another program, or you're older, we will sometimes add the medication Repronex. And this is, again, sometimes you might not use it in your very first cycle. It might be with your second or third cycle if need be. But this is typically a medication that has not only FSH but LH. And this is used to enhance or prompt a more aggressive response. So if you're on Repronex, and again, this is typically used more in an IVF cycle, because what happens with the insurance, before they'll allow certain patients to go on to IVF, they want to see what you'll do with an ovulation induction cycle. And they usually require sometimes that you do 2 or 3 of those before you move on to IVF if you don't get pregnant. So if you hear about Repronex, it too is a powdered med that would need to be diluted, and it comes with the diluent that you'd have to draw up. It's not in a pre-filled syringe like the Gonal-F. You need to do that, and we'll obviously show you how to work with that. Cetrotide and Ganirelix. They will use these in typically IVF cycles. They use it because it stops the production of LH immediately. We usually start it on day 7 of an IVF cycle, and it does the job similar to what Lupron does, but using less amount of it. So some people are on Lupron, some people are on ganirelix or Cetrotide. All of these meds, when you're taking them, pretty much have a certain amount of side effects involved. Probably the biggest one that I hear the most of the nurses here is that their patients find themselves very fatigued and very tired. And it's tough when you get rolling with taking these meds and all the testing that's involved. So just be mindful that you're not, you're not doing anything wrong, that all of this is pretty normal, feeling tired, and afford yourself, maybe going to bed a little bit earlier, or if you have the luxury of getting a nap in, because they can be pretty tiring. Cramping. It's not unusual to feel as your ovaries are being stimulated. I mean, some people do feel a little cramping, little twinges, little twangs. Out-and-out pain is not normal. So if you're having out-and-out pain, I want you to call your nurse. But feeling twinges, twangs, and bloating, all of a sudden you're saying, wow, I feel like, I'm really getting a little belly here. That's all normal. Okay? Because of that bloating, because of how these medications work, we want you to make sure when you're doing these cycles that you drink a lot of fluids. It helps keep you hydrated. So if you're not used to drinking a lot of water, I suggest that you get one of those water bottles or get an 8-ounce bottle that you can keep filling up, because it's important that you have 8 to 10 glasses of liquid a day when you're on these medications. By staying hydrated, it's going to prevent you from having hyperstimulation, which is probably one of the rarest but the most complicated side effect of doing these cycles. We are stimulating your ovaries, and it's important when you start that you be mindful that you keep that time that you're on this protocol free, because we need to monitor you very closely. We would be negligent if we didn't keep a close eye on you knowing that you're on these medications, because hyperstimulation is the biggest concern. Yes, we're stimulating your ovaries. We don't want them hyperstimulated. So when you're testing, when you get going, we're going to be testing via blood, which is the estradiol and progesterone blood test, the hormones, as well as an ultrasound. The ultrasound is going to be done at a baseline, whether you're doing IVF or ovulation induction. Again, we're not going to start anybody if there's anything going on, if your ovaries are compromised. Once we get you going, we'll then have you take the specific meds that was prescribed by your physician. Again, typically with ovulation induction, as I said, it's day 2 or day 3. With IVF, once you've done your day 21 progesterone blood test or you've been on birth control pills, we'll start you either on Lupron or we'll have you start your meds and then eventually go on the Cetrotide or Antigon, depending on what your protocol is. The baseline ultrasound is done on everybody before you start. After that, we're going to be monitoring you, and you'll be instructed when to come in. An average time on any of these meds before you're ready for either an IUI or egg retrieval is 10 to 12 days. Now, we know that you have lives. We know that you're busy. We know that some of you travel. We know that some of you have to be at certain places, whether for a wedding, whatnot. I have to tell you that if you know you're going to do one of these cycles, it is going to be very demanding on your time, and we ask that you try not to have to make a decision between testing or being in Chicago for your brother's wedding. It's not fair to you, okay? There's not a lot of flexibility when you start these cycles. We can't say, okay, you don't have to come in today because you have to be in Baltimore for a business meeting. That doesn't fly. There's not a lot of flexibility, so we don't want you to feel torn trying to decide, oh my God, what should I do? We ask that when you do this, know that you're expected to test when we ask you to. It's not because we're trying to be difficult or mean or not understanding. It's just once you get going, the anticipation and the expectation is that you're going to test when we need you to. Okay? So don't make things harder on yourself. It's hard enough doing this. We don't want you to feel like you have to make choices. So once you get going, you'll be asked to come back. to do ultrasound testing as well as blood work. If you're testing here at Brigham and Women's, this is what we call the 75 Francis Street site, testing here is done every day, 365 days a year. If it's a weekday and you're having just blood, you're going to go to the blood lab, which is right down the hall from the CRM office, Center for Reproductive Medicine. That's where I got everybody this morning before we came down to class. That blood lab is open 7 to 4:45. Because we need you to test to determine, based on that testing, where we're going from there. Once you start, we have the baseline testing, but depending on what you keep taking, do we adjust your meds, do we increase them, do we decrease them, it's going to be based on your individual testing. So we need the testing done early so that we can get the results, so that we can meet and review them with your doctors. So daily testing is 7:30 a.m. We ask you to be here no later than 7:30 in the morning, 8 a.m. on the weekends. So you need to now plan your lives accordingly. If you're testing here at 75 Francis Street, blood only, you're going to go to the blood lab on the 3rd floor. If you're having blood and ultrasound, you need to go down to lower level 1. That's the ultrasound department. Best way to get there is if you come in the front door, that revolving door, immediately on your right, there's a set of elevators. You go down to lower level 1. When you check in, ladies, there is a callback sheet there. We ask that you fill that out. You may or may not be familiar with that system, but basically, when you fill it out, it tells us not only where we can call you, but is it okay to leave a message if you're not there? We're certainly not going to call you at work and say, "Hi, I'm Kathy Lyons from the Center for Reproductive Medicine. I have Mary Brown's testing results today from her IVF protocol." Absolutely not. We certainly are mindful and totally respect your privacy and want to maintain that confidentiality. So if you are not able to take the call and you have a private voicemail and you write on the callback sheet, yes, you can call me and leave a message. That's great. Otherwise, we need to find you to give you your information so you know what to do next and when to come back. If you're not going to test here at the Brigham, we have satellites. One is at 850. That's on the eastbound side of Route 9 coming in. Some people find that convenient. It's kind of a quick in and out. I think they even have, I think the parking's even free. Here, unless you're want to come into the city and deal with the parking issues and the crowds, obviously that's your decision, but you know that it's tough. You have to keep mindful of the traffic. Although the ultrasound department also will give you a little leeway, they do frown upon patients that show up at 9 or 9:30. They do have the right to turn you away, which would be awful. So please, hopefully that won't happen. Just be mindful, now that the weather's good, at least we don't have to deal with, the winter business with snow and storms. But be mindful of what's going to be easiest for you. You do not have to come here. You can go to the Route 9 or the 850 Boylston Street satellite. We also have a satellite at Newton Wellesley Hospital, so that's pretty easy for you if you're coming the 128 Mass Pike area. And we also have a satellite in Exeter, New Hampshire, as well as in Danvers, the North Shore. So again, if you have, that might be a little bit easier for you, talk to your nurse, because wherever you test, that's where you'd have to complete the whole cycle. When you're approved for these, it's kind of like a global umbrella where the testing, the monitoring, the meds, obviously everything is included in that insurance coverage. They do not want you testing one day here and one day there. That is not going to be allowed. So wherever you test, you have to test there for the complete duration of the protocol. So if you have any questions, again, let us know. If you're testing other than here at 75 or 850, you need to have orders faxed to those satellites. We do it all the time. It's not a problem. However, in your packet, you're going to see a standing order for your blood work as well as ultrasound requisitions. Those are only going to be accepted at a Brigham site, such as here or 850. If you're testing anywhere else, we need to fax the orders, and your nurse will discuss that with you. You would also then need to call and make an appointment with the satellites. Here, there's no appointments. It's, that open time. It's basically first come, first serve. They'll start drawing bloods as early as 7 a.m. down on lower level 1. Scans would start at 7:30. And I believe the same is at 8:50. The only thing with 8:50, if you start there, they're not open on the weekends. So if you want to test there during the week, you'd come to the Brigham, this site here, on the weekends. Whenever you test, make sure you fill out the callback sheet so we can reach you and give you your information. So every day after you test, again, we have you test early, which I know is difficult, but we need to have those test results in order to meet and discuss them, review them with your physician. The physician is then going to give the nurse orders. We in then turn are going to call you in the afternoon with instructions. Callbacks in the afternoon can be anywhere from 2 to 5. We like to remind you, if you don't hear from your nurse by 4:30, I want you to call her. Okay? That should be a red flag. Why didn't I get a call? And typically, you know, I have found personally in the past that the person's cell phone, where they said, you know, I could leave a voicemail, the voicemail is full, so I can't leave the message, and they didn't leave another number. So it's a good thing maybe to leave 2 numbers, or your partners. I mean, obviously, just let's cover all bases. But in the long run, if you don't get a call by 4:30, red flag, why didn't my nurse call me? Please call. Don't wait till 9 o'clock to call the fellow who's going to say, they're not at the hospital. They don't have access to your records. They don't know. So it's just easier to call while you know there are people in this building, because basically by 5 o'clock everyone's going to be heading home. Okay? As always, I've had patients call, I got your message, but it got cut off, or I don't understand it. Call as soon as you can to get it clarified. Okay? We appreciate that. As you're monitoring, we're watching your follicles grow and develop. We're watching the estradiol level, which is the gauge, the trigger. The higher that estradiol goes, we know that you're making eggs. I was always taught an estradiol of 250 was equivalent to 1 mature follicle. So if you get an estradiol of 750, you would expect at least 3 mature follicles. Whether you're doing IVF or ovulation induction, we're wanting to see those follicles grow and develop. If your estradiol level is real low, your follicles are very small, there's a good chance they might want to increase your meds. The opposite would happen, obviously, if your estradiol level, I've had people come in for their first testing, their estradiol level is 1,500, and you're like, whoa, we need to tone you down. So we can either have the pokey response or the exuberant response, and we need to be closely mindful of that. That's why we need you to monitor, and monitor frequently. People say, well, how often am I going to have ultrasounds? Typically, you have one at baseline, and then usually 7 days later, we have you come back for the second one. Keep in mind, whatever day for IVF that you start your meds, it's always going to be called cycle day 2. OI patients, you could pretty much, you know, base your start date on cycle day 3. Anything off the ordinary, we would discuss with you when you meet with your nurse. Most patients, as I said, you can pretty much guarantee a 10 to 12 day on these meds. Now, when we order your meds, we order them for 10 days. That's the allowance your insurance companies give us. So if we order you a 10-day amount based on a certain dose, and somewhere along the line, if that dose is increased, you're obviously going to need more medications. Be mindful that all of your medications, when we order them, come with refills. As you start to run low, and mind you that I said run low, not run out, you need to call yourselves directly to that pharmacy to get refills. So it's your responsibility to keep an eye on your meds, knowing if the med dose is increased in any way, you're going to need to get more. And we give you that pharmacy number so that you don't have to call us and wait for us to call you back. We're going to put that responsibility right in your lap so that you can call and get what you need. And that includes if you need any more needles, syringes, etc. Okay? When you order the meds, they're going to deliver them. They're going to call you and do all the insurance, all the paperwork, all that stuff, and make arrangements to deliver them usually right to your home. Most of these pharmacies are mail order type infertility pharmacies that have all the meds. We don't recommend, and a lot of them now won't let you go to CVS or Walgreens, any of the chain stores. They don't have what you need, and are not or if they have them, it takes 2 or 3 days to get them. So basically, when we talk with you about the pharmacy and the meds and where to get them, it's going to be pretty much based and mandated by your insurance coverage. Okay, so we're testing, we're watching. If you're doing ovulation induction, we're hoping for at least 2 follicles at around 34 to 36 millimeters before we trigger you with HCG. With IVF, we're hoping for the lead 2 follicles to be 36 millimeters before we trigger you with HCG. HCG is human chorionic gonadotropin. It's the hormone of pregnancy, but it's also the medication that we use to induce ovulation. If you're doing ovulation induction and having intrauterine insemination, IUI, or intercourse, once you take the HCG, 36 hours later you would have your taking your HCG, we have you take it at midnight. 12 hours later at 12 noon the next day you would have your first IUI, and then 24 hours after that the second IUI to cover the 36 hours where we anticipate ovulation to occur. With IVF, this is going to be a timed medication. Obviously, everyone is going to be retrieved individually, so you would be assigned a specific time to take your HCG. This is the first medication if you're doing either OI or IVF. This medication is intramuscular, so this is what some patients lovingly refer to as the big needle. This comes in a box where there is a powder. Everyone pretty much is getting the same dose, 10,000 units. You get a vial of diluent. There's 10 cc's in here. However, you only mix the powder using 1 cc. Why they give you 10, I do not know. But I've had patients in the past say, well, they gave me all this, they must want me to use it. Your syringe is what we call 3 cc's. This is 10 cc's. So to get this entire amount in, 3 goes into 10 how many times? You literally have to give yourself 4 injections. That is not what we're telling you to do. I had a patient do that once, and I'm like, wipe when you're ready to start. You're going to take your alcohol wipe. You're going to wipe both bottles. You're going to open your 3 cc syringe. Pull the plunger to the 1. Whatever you want to take out of any of these vacuumized type bottles, you want to pull down the syringe to the corresponding mark. I want 1 cc, so I'm going to pull the plunger to the 1. You're going to inject that air into the vial and tip the vial upside down, pulling back. I like to go a little bit beyond the 1 and push up because it gets rid of any of the bubbles or air. Now, this, you don't need it anymore. You would take this 1 cc of diluent now and put it into the bottle of HCG powder. Let it dissolve on its own. Do not shake it. Prior to taking that medication out, again, you need to pull back to the 1, inject the air. That'll make taking the medication out much easier. Otherwise, you're going to meet resistance and be pulling. I've had patients call the next day crying, I couldn't get the medication out of the bottle. Now, as you're extracting the medication, make sure the needle is under the water. If you've got it up above, you're going to be pulling back air. So let's say you're doing this and this happens, and you still have medication in here. Just bring the medication to the top so that a little bit comes out. Not too far so that it's spraying all over the place so you miss it. And then just go back in and get what you need. Once you've got the HCG completely drawn up, it should be 1 cc. Because you've gone in and out of that rubber stopper a couple of times, this needle is now dull. And in order to have the injection not be as uncomfortable as I'm sure you're anticipating it is, you need a new needle. Nice and sharp, it's going to work much better. We don't give you a lot of extra big needles in your kits because you don't need them. So what you're basically going to do is twist the needle off. Unfortunately, you're going to have to open another syringe and take that needle off and then put it on. Okay? When you're doing this injection, as I said, unlike the sub-Q where you would just pinch in an inch and This needs to be IM, which means we recommend that you use your butt. So here's my nice little butt. And you're going to just imagine one of those cheeks, dividing it into quadrants. You are going to stick to the upper outer quadrant. So this is an injection, ladies, your partners is going to really need to give you. Can it be done by yourself? It can, and we've had patients that have had to do that, but it's just easier for the partners to do. So this is where a little extra real estate comes in handy. So when you're doing this, in the past, when you've done the sub-Q, I've told you to pinch an inch. You're now going to stretch the skin. So stretch the skin, partners. Again, you're going to aim like a dot or a pencil. Quicker is better. For those of you that kind of hesitate, do it. Much quicker, doesn't hurt as much. Stretch the skin, 1, 2, 3, all the way in. Once it's in, these two fingers, you're going to hold it in place. Otherwise, it's going to be dangling. So you want to hold it in place. Before you push on the plunger, you're going to pull back. You're pulling back to make sure that you don't have a blood return. Now, thank God your butt is not what I'd call a vascular part of your body, but if the needle did bump up against a vein, you might see some blood. We don't want you to inject. What's going to happen is, partners, if that happens, pull it out, twist this needle off, get another one, put it back on, and then go to the other side. Don't throw the medication away because you're only getting 1 box of HCG per cycle. Okay? So once you're in, wipe it with alcohol, stretch, 1, 2, 3, go in real quick. People say as we're teaching them, how far do I go in? All the way. Quick. Once it's in, press on the plunger and then pull it out. This is a one-time IM injection for those of you doing the ovulation induction. For those of you doing IVF, you'll need progesterone after your egg retrieval. Remember, when you think of the cycle, each follicle has an egg. When ovulation occurs, that follicle ruptures, the egg is released. That ruptured follicle that remains behind produces corpus luteum. Corpus luteum produces progesterone, which is going to help maintain, thicken that endometrial lining, hoping for implantation in a pregnancy. With IVF, when they talk about this with you, they're going to go in and retrieve all those follicles with the eggs inside. So there's no follicle left behind to produce the progesterone that you need. So you have to take it as a supplement. So those of you doing IVF, this is progesterone in oil. This is an IM injection that you'll be instructed to take after your retrieval. It is also going to be 1 cc, usually in the evening. This is a 10 cc vial, so there's 10 doses. Each will figure out to be 50 milligrams is 1 cc. So there's 10 cc's in here, 10 doses. It has to be IM. So this is what you'd be doing if you're doing IVF. If you're doing ovulation induction, blue folder people, this is not pertaining to you. Now, if for some reason you say, oh, Kathy, I can't do that for 10, 15 days, whatever, it's actually going to be for at least 18 days until you test for pregnancy, those of you that are doing IVF. You can take it as a vaginal suppository. So if that's something that you know is going to be an issue with the injection piece because your partner works nights or not always available, again, we want to work with you. You check with the nurse. Okay, so don't, I saw a lot of faces go, check with your nurse. We can work with you. So those are the meds as far as the injections. There's nothing oral usually except if you're on the birth control pill. They're all by injections. And that's why we have class to meet with you, to make you feel comfortable. When we meet with you upstairs, you're actually going to be handling the needles and syringes, drawing up using just the saline. It's not real meds. Okay? Okay. We're watching your follicles grow and develop. When it comes time for the HCG, the OI people, again, you'll be instructed to take that at midnight. You'd not take any more of the Gonal-F or Follistim. You'd come in the next day at 12 noon for your first IUI and then 24 hours later for your second IUI. We then tell you to test for pregnancy, usually 16 days later. If you're doing IVF, you'll be told to take the HCG at a specific time. And again, when we do part 2, she's going to take it from there, what happens after you take your HCG. But typically, if you take your HCG, let's say tonight at 9 p.m., your retrieval would be 36 hours later, or Saturday at 9 a.m. Okay? Whatever time you take your HCG, if you're doing IVF, 36 hours later is when you'd have the egg retrieval. And she's going to go over in the second part what happens when you go on to that piece. During all of this, we know that, as I said, things come up. So again, if there's a problem and you anticipate, gee, is there any way that I can, maybe not come that day for testing, let us know. As I said, there's not a lot of flexibility. We need to keep a close eye on things because we are concerned, we don't want you to get hyperstimulated. Hyperstimulation goes beyond the bloating and discomfort. These patients are out and out. They'll call and say, I can't move. I look like I'm 8 months pregnant. I am so bloated. I gained 4 pounds overnight. What is happening is, usually you might also notice that you're having nausea, vomiting, diarrhea. On the outside, you're feeling and looking dehydrated, and your body's saying on the inside, hey, we're losing fluid. Let's start saving it. And that's what happens. So you see the weight gain. You see the bloat. And the telltale sign is when you have difficulty breathing or shortness of breath, because now the fluid that your body's taking on is collecting around your lungs. So at any time, if you have any of those symptoms, nausea, vomiting, diarrhea, weight gain, bloating, shortness of breath, please call us. This is very rare, but again, it's something that we need you to be aware of so that we can nip it in the bud before it goes to severe hyperstimulation. There's mild, moderate, and severe. It happens in less than 2% of the thousands of cycles that we do, but we need for you to be aware of it. And we'll kind of tip you off to the fact, and you'll know it, because if your estradiol is 4,000 and you have 30 follicles, wow, I did okay here. Probably too good, but we want you to be aware of that so that we can keep a close eye on things. Also, because of the stimulation, your ovaries, think of how tiny they are now filling up with these follicles, so they can get heavy. I always tell people, think of a water balloon. Remember when we were kids, you'd fill a water balloon up, and if you held it, it would, obviously sink down. That's what your ovaries tend to get like. So if you're doing a lot of heavy-duty exercising, bending, twisting, Pilates, stretching, your ovary, again, this is very rare, but it can happen. They twist and torse. So that's ovarian torsion, very rare, but again, mindful when you're doing this. We know that some people have a specific exercise regimen. You really should scale back. You shouldn't be doing any, heavy bending, twisting, stretching while you're doing this. Walking, jogging, okay, but anything beyond that, you really should kind of taper it off until after you finish the protocol. Just want to make sure I didn't forget anything. When you start the protocol, or even if you think you might get your period on a weekend, this is basically for the OI people, let your nurse know so that we can pull your paperwork. Again, you have the option if you get your period, like say you got it on a Friday night, you would need to baseline on day 2 or day 3, which would be Saturday or Sunday. We want to make sure that we have your paperwork pulled, so let your nurse know, gee, I think I might get my period on the weekend so we can have the paperwork done. IVF, if you get your period on a Friday night, you can call the nurse Monday morning. Just know from that point on, and you'll know when we discuss with you, there's usually no unprotected intercourse advised. So from that point on, that's how you get started. We'll order your meds well in advance. And again, when I told you when we go upstairs, we'll discuss how that happens, but everything is done through the mail order pharmacies, and they're really good. We've worked with a number of them now, and they will get you everything that you need, and if there's any pre-authorizations involved. If you have any questions about your coverage, you really should call your insurance companies because they'll tell you if there are any, glitches, because sometimes you don't realize that's going to happen until you get going, and they'll say, oh, we'll only allow so much, over a certain period of time. So you want to let them know that you're starting and make sure that everything's covered, because co-pays are different. We are only allowed to order 10 days. So if you need more than that and they need to send a second shipment out, it sometimes involves another co-pay, which is tough. But it's not us, it's the insurance companies. But if anything you need extra in addition, you're running low on supplies, syringes, needles, they'll get them to you. Everyone has consents in their packet. The OI, you only have one. The IVF patients, there's a number because it's going to involve, let's say you get X amount of eggs, then X amount fertilized. They're only going to put so many back. What are you going to do with the ones that were not put back? Most people have the option to freeze them, and then there's consents pertaining to that. So that's going to be a little bit more in depth, and that's what part 2 was going to be for the IVF patients. So remember, when starting, you want to call the nurse. We'll get your meds ordered, make sure that you're ready to roll, that you understand. These cycles can last, like I said, 10 to 12 days. Some people are done a lot sooner. Some people take a lot longer. Some people we have to start very slowly depending on what's been going on. I mean, all of you know why you're here, whether it's a female issue or a male factor. So depending on what your history is, what the testing up to this date has shown, will depend on, how aggressive we're going to be. So just know that throughout the course, I like to just reinforce all the time that we're here for you. If you have any questions, please don't hesitate to ask. There's no such thing as a stupid question. We know what's involved, the emotional, the financial, the psychological investments everybody puts into these cycles, and if something can be done to help you to make things easier, that's what we're here for. We want you to call us. Again, there's always someone available. If it's not the 9 to 5 office hours, there's somebody on the off hours. And again, we encourage you to call if you need any help. Okay, so at this point, I am going to break for the IVF group, so you can plan to have some coffee. There's a cafeteria right around the corner, and they will be back down for the second half for you to finish up. They also have a social worker that comes down. It's Annie Gagan. Obviously, there's a lot of emotional as well as a physical piece to these protocols, and Annie just likes to make herself acquainted with you to let you know if anybody has, any issues or feels they need to talk to her or wants to. They just like to make themselves available to you, because it's tough. This is a tough protocol, and the meds can cause a range of emotions. You might be all ready and okay to do this, and you start taking the meds, and you're just crying for no reason. It's tough. And when you add in the testing and the traveling and all the emotions, it can be a roller coaster. And she's awesome, and they deal particularly with our patient population. We're understanding, we know what you're going through. So she likes to come down for the IVF piece. So you can, for those of you that are staying, you'll meet with Annie. The rest of us are going to go upstairs and get to actually do the injections to make you feel more comfortable, if that's the right word, but at least you won't be working from just you not knowing what's going on. We try to do our best. So at this point, I'm going to stop and break, and we'll see you upstairs. Okay? Thank you very much.